And so I do not believe that Katie's going to be able to join us today. And then Crystal actually is not feeling well. So Crystal will not be joining us today either, but both of them will be watching the video that I believe we are recording, and they'll have that to reference. But they were able to attend the small groups. And so we did have some great conversations with them, and they will be missed today. But I just wanted you to be aware that those two won't be here with us today.
Okay, thank you. Thanks. I hope that everything is okay for them, just as I hope it is for all of you. And knowing that some people may not have their cameras on, so they just hear a de-identified voice, then I should have said this is Eileen Barrett, and it's great that people were able to come together. And I know that we've done this for some time, but I firmly believe that it helps with relationship building, and people seem to think that they like it. So until I get feedback that you don't like it, then we're going to continue doing our sort of introductions that have a question. So maybe what we'll do this time for our question, which I'm actually, for my work, I'm in Philadelphia, and I am wearing a magic bracelet that people may or may not be able to read, but it was directly the thing that led the Phillies to win over the weekend. So I want to make sure that people know that. So I thought that maybe what we'll do is we'll call on people, ask you to say how you prefer your name to be said, and where you are today, and if you can commit out loud to Phillies, D-backs, or isotopes. Because they sound okay, right? How can we not give a little bit of local love for the isotopes? So with that, then maybe where we will start is with Alan.
Good morning, Alan Plymell in Deming, New Mexico. We've just turned the corner from the hot summer into the fall. We had a little bit of rain shower last night, expecting some more today, but the lizards around here are still carrying canteens.
Thanks, Alan. That's really vivid. And would you remind me, would you say Diamondbacks, Phillies, or isotopes? Or it's okay to have choice D, which is I don't know what you're talking about, and my money is on those lizards carrying the water cisterns.
There are too many choices. When you get past one, I have trouble.
Okay. All right. Totally reasonable. So next we'll go to Kathy. If she's able to unmute herself.
Hi, good morning. Yeah. I'm Kathy Augeri. I'm calling in from Albuquerque today, and I'm going to go with the isotopes. Yeah.
Okay. Thanks.
Thanks.
And Libby? Oh, thank you, Kathy. Libby?
Hi, good morning, everyone. I am calling in from Santa Fe, and I am going against all of the answers and say I'm a Twins fan, Minnesota Twins. So.
Okay. Paving your own path. I like it.
I am. I didn't really identify with any of the answers, although I like the isotopes, but I'm a big Twins fan.
Okay. I'm a twin, so I like that. Eleni?
Hey, good morning, everyone. I'm Eleni Bukavalis. I'm calling in from Placitas, just north of Albuquerque. I'm embarrassed to admit that my response to Eileen's questions were talking about baseball teams. Baseball? I don't know. I got nothing.
And that is okay. Gary, how about you?
Gary French, I'm here in Santa Fe today across the hall from Libby. Hey, Libby. The isotopes, I will let you know that the isotopes were recently sold to a New York conglomerate called Diamond Baseball Holdings, but they are going to keep the isotopes in Albuquerque. So there's the hook and the good news. So we can still go to games.
Okay, good. Thanks. That's terrifying for a moment. Brenda?
Good morning, everyone. Brenda Martinez, staff manager here, calling in from Santa Fe as well. I would say from the three choices, the isotopes.
Okay, thank you. And Matthew Clark.
Good morning, Alamogordo, New Mexico, Matt, and I have to go against the grain. If I were to follow baseball, go Brewers.
Wow, bold move. I like it. I like it. And
Gotta stay with my brew crew.
okay. And Mateo. I think Mateo Pearson. Matthew Pearson. Maybe he's unable to unmute himself, and we'll circle back to him. Haley.
Morning, everyone. Haley Peterson. I'm calling from Albuquerque. And of those options, I'll say isotopes, but I'd also say I'm just a big fan of like stadium food at a game.
Okay. Which stadium has the best food? Any thoughts? No, that's okay. I like stadium food too, and stadium energy. And Chris.
I'm Chris Woodward, and I'm calling in from Santa Fe. And I don't really follow baseball, but I guess I'm sort of a fan of the Nationals. And so, to your question, my choice would be the Diamondbacks, purely out of spite, because the Phillies took Bryce Harper away from the Nationals, and I resent them for that.
There's a lot of valid resentment toward the Phillies. I totally get it. Mostly I'm a Phillies fan because it's good for my marriage. And Dominic.
Hello and good morning, everybody. Sorry for my being a couple minutes late. We are getting out of a different meeting. I'm Dominic, and I'm Medical Cannabis Division Director out of Santa Fe. And I guess that the question is favorite baseball team?
Oh, thanks. I didn't give you context. It's just more of a timely one, but I love that people are a little more time sensitive. So, but I love that people are paving their own way. But the question was Diamondbacks, Phillies, or isotopes.
Oh, for the
But
World
totally
Series.
valid to say,
Okay.
I have no idea. I don't care. And any other team.
Well, I actually don't even know who is playing this year because I haven't paid attention. And quite frankly, it is one of those where I have my own opinions about organized sports. So I will say at this moment, I don't care. So.
Always a valid response. And I think that, let's see, Andrea?
Good morning, everybody. And I'm not going to go off on a rant because I am actually a Cleveland Guardians fan. So I won't talk about our long-suffering history of always, we were up 3 games to nothing. And I just can't even talk about it. But Phillies all the way. So that's who I'm rooting for.
All right, thanks. And I'm going to ask if, is there anyone who I missed? Because it may have been that people joined. And that I missed when you had joined, because if so, would love to hear from you. And if you're someone who just wants to be able to put in a second vote for the Twins or the Brewers, that's also okay too. Okay, so it sounds like that nobody else, but strong opinions about not the Brewers. That's okay. So thanks. So thanks again for going with the team. I really appreciate it. And I think that it's nice for us to start with a little bit of a smile, a little bit of a team building, that sort of thing. And you'll see that I did, for those of you who are able to look at your screen, I understand people may be driving, they may be multitasking, may not be able to, but we did add to the chat the agenda, which you also received via email. And it's sitting in your box right now. If you haven't seen it, that is waiting for you. And next, we were going to move toward the update from the medical cannabis program. And I would love to hear that update, and I will start to mute myself.
All right, so this is Gary, and I'm going to go ahead and take care of the update for today. I'd like to start off by sharing that we have 88,197 enrolled patients in the program, and then that is of September 30th. So that's the September data. If you if you go to the website, come, the first part of November, you'll see the October numbers. So again, I invite you to always, if you are interested in some of the data about the demographics of those participating in the program, it is available there on our website. And it's under the resources section, and the data is there, and we publish it each month. Now, in addition to that, I'd like to always shout this out, that we have over 55,000 patients registered using the online patient portal. I think this has really been a success. And again, the number of providers participating also continues to increase as well. And we continue to fill in these little gaps of providers that used to certify patients years ago, and now they're coming back and getting registered as well. But 55,000 registered to use the portal. So, New Mexico is making gains, and I think that we're one of the only states, if not the only state, that is all electronic. So when we have each month, we have a meeting with some of the other states. Oh, and Hallie's joining us, and they always ask how we're doing with our numbers. And actually, it's we are sort of the stars there because we are utilizing this online patient portal. One thing I wanted to bring to your all's attention is that back on August 29th, the FDA did make a suggestion to the DEA that they consider rescheduling cannabis from a Schedule 1 to a Schedule 3. So I'm sure that you probably heard that, or in the news media there. But again, we'll see what DEA does. Historically, they followed the FDA's suggestions. This is, of course, unique times. There's a lot of politics rolled up into cannabis as well. And what does a move from Schedule 1 to Schedule 3 actually mean? Is it more impactful on the recreational programs or the medical programs? And it's all going to be very interesting to see how that plays out. And I did want to talk a little bit about the small groups, and I think I'm going to share this screen so that we can actually see those. I did send this information out, but if you ever want to reference, okay, who's in my small group and how do I reach out and contact them? We did move that document to SharePoint, and it is right down here at the bottom. And if you just click on that, then oh, let me do this then. I have a different version. There it is. So these are the 8 small groups. And again, thank you all for getting back to us with what you sort of, were more interested in. We did actually place people in 3 different groups just because of numbers. And again, everybody's got a number 1, 2, and 4, or 1, 3, and 4. So hopefully you're jazzed and energized to participate in these small groups. Now, that being said, we have had some small groups already meet, and we have had some of the small groups start putting things into the document phase here. So let me just share one here. Here's road safety. You can see we sort of have an introduction going here and some other, perhaps data sets that will be shared. And if we go to, I know that child access, we discussed this at length yesterday, really had some great brainstorming. And we've already actually planned a follow-up meeting for that group. And as the small groups meet, and again, we'll have some opportunity to do this today, one thing that we sort of honed in on is, the topic. Some of these topics are very, very, very broad, but how do we sort of narrow that focus, and what data do we have that we can present that really supports that? So those are just things to keep in mind as the small groups meet. But again, we've been very successful with some of the small groups meeting already, and hopefully that will continue at the end of today. So that's all I had to share as far as updates, Eileen, and I'll turn the time back to you. Oh, and then Hallie has joined us, and so I just make you aware of that.
Yeah, my apologies for being late. I got a new iPhone and I had a second, 2-factor authentication, and the authenticator was on the old iPhone. And anyhow, I'm glad I could make it. sorry for that.
Hallie, this is Eileen. We're glad that you could make it as well. It's always wonderful to see you. And we have all had that happen also with the Zoom updates when you're like, wait, really? 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 Today, right now? So we've all been there. Yeah, and great to see you. And Hallie, we also did our introductions. And in addition to who we are, where we're calling from today, asked people to say, answer the question, Diamondbacks, Phillies, Isotopes, or I don't care.
Well, I don't really care but Phillies because I grew up there, and I'm happy to see the Eagles continue their dominance. So football's a thing, but baseball's not. So, but I'm happy for my friends who really want the Phillies.
Okay.
Okay.
You're not alone. Okay, thanks. And thank you for going with it. Thanks. And Gary, also thanks for that great update and for showing everybody where they can also, well, the great update period, also for reminding people about our small groups and who we have the privilege of working with, and also how they can be reminded of that information. And team, we are going to be, this meeting is deliberately going to run a little bit short. And the reason is so that people can, we know that it is hard for people to find time to work together. The fact that you took time today to work together or to join this meeting, it speaks to your dedication. It also, then we thought that assuming that we do end early, that maybe people can connect for a few minutes about some of the small group work. Gary said that, but I just wanted to allude to that is by design today. Yeah. So with that, one of the next thing that we did have the, oh, actually, maybe I'll pause there and to see what questions do people have about their small groups, if any. Okay, so I did my usual counting to 7 by myself silently, and so I didn't see that anybody raised their hands or otherwise gestured frantically or unmuted themselves. So then we'll move forward. And the next thing that we were going to have is to continue the tradition that was introduced by Martin, that he had recommended that we could consider doing like a professional development while we're all here, and journal club, and that we've seen Crystal and Eleni had done really nice jobs before. And so I hope to do half as well as they did with a journal article that I came across that really was it gave me a lot of pause. And so I'm gonna try to share my screen without showing everybody my 100 open windows. Well, or you can just judge me for my 100 open windows. So I think that now I'm going to ask for maybe if anybody can tell me if you are seeing my slides.
Well,
no.
We can see you really big. Oh. Is that how we want you to see your head really big and then the slides next to you?
Okay, I wasn't trying to show my head at all. So
that's a new feature, I think.
It's confusing. I'm going to stop sharing.
You can do this on FaceTime too, but if you can enlarge the slides more so than your head, perhaps.
Okay, that is a little bit mortifying. Certainly I need a haircut at best. That's like the minimum thing that I can say about that. So I'm going to try that again one more time with if I do.
Sometimes takes a little trial and error.
It does for me. And
Eileen, if when you go into share, if you do just the window and share just the window for the PowerPoint, it'll show it that way. So like when you go to the share screen, it'll have like share content presenter mode screen below that window. Yeah, there you go.
Yep.
Yay! Thank you for walking me through that. I appreciate you very much. It does mean that I'm going to turn it into, well, no, because I still want to be able to see you. And if I go to presenter mode, then I won't be able to see if anyone raises their hands or is telling me, Eileen, you're going in the wrong direction with this. But so anyway, so here we are with the article. This was an article that came out in the Annals of Internal Medicine, and you can see it was earlier this year, and it was one that really gave me pause. It was really, I learned a lot from that. And as you can see, it's effects of U.S. state-based cannabis laws on treatment of chronic non-cancer pain. And in this case, although it's quite a lengthy article, I just have some excerpts, and they note that there's rigorous evidence reviews that covered largely identical bodies of research have come to some disparate conclusions about the effectiveness and whether the risks for cannabis use for chronic non-cancer pain, including addiction and potential adverse mental health side effects, outweigh the benefits. Also, they note that prior studies have suggested an association between state medical cannabis laws and reduced prescription opioid use, interpreting this finding as being driven by substitution of cannabis in place of opioids for chronic non-cancer pain. Of note, the research is limited by general population and repeated cross-sectional samples in which most people do not have chronic non-cancer pain, and changes in pain treatment within persons over time are not observed. So I think that that's interesting that we don't maybe have all the data that we thought that we did. And then they note that there is some data that there are people who use medical cannabis are more likely than their counterparts to use and misuse prescription opioids. That was a surprise to me. And a prospective study found no association between cannabis use among people with chronic non-cancer pain and future prescription opioid use. So a lot of things that were surprising to me. So what they did was that in this case, what they looked at these characteristics of within states that have medical cannabis laws, and they looked at the patients within those who have chronic non-cancer pain, and in the 4 years before implementation. And you can see at the, I don't know if you can see my mouse, but that in the 4 columns, the second column indicates the states with medical cannabis laws, which is over 150,000 people, and then the comparison states in the next column is over 430,000 people. So what they look at is all these different patient characteristics having to do with certainly their average age. What I don't know if they're doing sex or gender in this case. Regardless what they're designating as female, so I'm assuming that they're saying sex instead of gender, that they're noting about mental health diagnosis, percentages, substance use disorder diagnoses, and a comorbidity index. And then they look at at those characteristics, also the features of the chronic non-cancer pain treatment, noting prescription opioid treatment, and then sort of a lot of details there and metrics there, and then guideline concordant non-opioid treatment, and they look at a lot of details there. And then this is just sort of who are we looking at, and what they see is that there's a lot of ways that these two groups were pretty well matched. The ways that they weren't is that there was a little bit more of a difference in some patient characteristics, but generally not with the chronic non-cancer pain treatment per month and that approach. So what they looked then, or what they compared in this case, was that what you can see on the x-axis or the bottom is the type of chronic non-cancer pain treatment. So they have opioids, prescription non-opioids, and then they have procedures. And then on the y-axis are going up and down. So this is really interesting. They look at the percentage point difference in the proportion of patients receiving treatment attributable to the law, meaning that the law is on medical cannabis. So what they're looking at, of course, is like, well, again, what is the difference that is represented here? And this is just within the first 3 years of law implementation. So of course, this absolutely could change over time. And I think that there'll probably be more studies looking at this. And what they can see is that what you might be able to see, which would have been handy if they had included just like a dotted line at 0, I think would have been really, really helpful, just to give us a little bit more context, not just solely on the y-axis. And that they see that the percentage point difference, it's not actually, it doesn't look like a tremendous amount. They also, in this case, again, are looking at for 3 different types of, for patients, again, with chronic non-cancer pain, and they're looking at whether they receive any opioids, any non-opioid prescription, or any procedure. And they're looking at the differences between people who have, or the average for if there is a cannabis state law, and then sort of the control. And they're seeing that these lines are really, the dotted line and the solid line are nearly not completely, but they're largely overlapping each other, which that was a surprise to me. So next, what they're describing is a little bit more detail about how the estimated effects of what was the law and the volume and the dose of chronic non-cancer pain treatments among patients receiving these treatments in a given month and during the first 3 years of law implementation. So again, this is just in a given month. And then on in the 5 different columns that you can see on the left-hand side, they're dividing them up by the type of non-cancer pain treatment outcome. And that those are things, the opioid prescriptions per patient, opioids, the days of supplied opioid prescriptions, the percentage of patients prescribed opioids with an opioid prescription greater than 7 days. Also the milligrams of morphine equivalents per day, and how many people have the patients who are prescribed opioids with a milligram of morphine equivalents per day greater than or equal to 50, because people may know that there's some data going back to a large database in Canada that suggested that is really where we start to see that people have a difference in their risk for dying from opioids, and prescription opioids in this case, and that was what advised like the CDC strategy. And then they talk about the non-opioid pain prescriptions per patient prescribed non-opioid pain medication and procedures for a patient with one or more procedures. And then they're comparing and looking at people with cannabis laws, states that have cannabis laws, and then states this like control of the idea that they don't, and looking at the averages in a given month in the 4 years before the law, the average in a given month in 3 years after the law, and then what are the difference between the two. And I really just over talked that. But on the right hand side, what you can start to see is it's interesting that they've characterized it as the effect of the law. I think that maybe wouldn't have been the term. I probably would have characterized it as a little bit different than that. But that they are noting what is the difference and what is the confidence interval between them. And what we do see is that the confidence intervals are possibly not as wide as one could have expected or could have thought. And I think that the door swings both ways, because I'll get back to that in the end. So I'll come this way. So next, just also what they're describing in a different way is the volume and dose of opioid prescriptions per patient prescribed opioids in a given month in cannabis law and comparison states. And again, this is looking at a macro level, not at a given patient. But what they're here looking at when the law comes into effect in 4 years before or 3 years after, that the opioid prescription days in the on the left-hand side with the days supply per patient in a given month, and seeing that there's not really a difference between the states with laws and the states without. And then on the right-hand side is the doses, that they're seeing that although the doses are going down, that a little bit surprisingly, they're not seeing that it's the state level that is what's predicting that. And in the conclusion, what they talked about in the body of it was that there also are some social norms at play here as well, with regard to how people are approaching their prescribing, and also how people are approaching prescribing. So I recognize that this is just like the one sentence in that concluded the paper, was that they thought in this study did not identify important effects of medical cannabis laws on receipt of opioid or non-opioid pain treatment among patients with chronic non-cancer pain. What I didn't show was that they also described how, there are people who say that this, everything that everybody here has heard, which is that it could make opioid prescribing worse, et cetera, and that they're not inappropriate opioid prescribing worse, that they're not seeing that. They also, at this level, didn't see that there was a difference in the opioid prescribing in states with laws and without. Of course, like all studies, this one does have limitations. They note that it has a non-experimental design, and they also say to some extent there's some limited statistical power because there's a low number of states. And maybe I will stop share. And also I realized I could put the article in the chat if anybody wants it, and to see what questions that you have. I think I'm not sharing anymore, right? Yeah. Okay.
Is this in Taro? Is Taro already?
Oh, that is such a great question, and this is embarrassing that I did not. I have not put that in there yet, I don't think. So I will do that today.
Thank you.
Oh, thank you. I should have done that. Maybe I'll say what people are thinking of any other questions is that I feel like this sort of builds upon a little bit of something that I heard Gary say, which is that when the state legislature was sort of writing the rules, I think there's a common misperception that that there are easy fixes for people with chronic cancer pain, and it's not easy. Like people don't choose it, and they don't end up with a really difficult to treat diagnosis that ends up stigmatizing them because it's easy, right? It's a product of so many different things, and I think that there are thoughtful people who wish, like I do, that there is an easy answer, and that there's a lot, and that maybe that would be all that we would have to do, but really there's a lot more that the patients need and deserve.
I'll just make one point. When I saw this last slide of the reducing amount that started before the laws and then after, it very much reminds me of, and the comparison may be spacious, but it's an ecological study. It's not because as you said at the end, a true controlled clinical trial of some sort, right? However you want to, longitudinal study. But that line looks very much like cervical cancer. But the line drawn was pap smears, and when they were introduced and started to be used at a higher rate. So the question is, on an ecological study like this, how much conclusion can you really make based on a simple timeline, right? Where also other things, as you mentioned, the social norms are changing as well. But I'd love to read the original study to see more of the nuances there.
Yeah, thanks. I'll
Hallie.
put that in. Lenny, go ahead.
Sorry, that's an interesting comment, Hallie. You're suggesting that it may just take more time for us to see the impact of this.
Phone was ringing in my hearing aid ears
Sorry.
at the same time you were saying that. But well, it's yeah. I mean, it's always hard to suggest cause and effect from these kinds of studies, right? Because they're correlative studies; they aren't causative studies per se. But it just, I saw this and it looked just like so I was an advocate for pap smears and was doing them, in primary care and having all my patients, and in public health way, advocating for them through public health departments, et cetera. And then one wonders over time, because you were already having the trend of a reduction in pap smears in, cervical cancer. So one wonders if even if there were some statistical finding here that seemed to indicate a correlation of cause and effect. I'm not sure what you can actually conclude from this kind of a study. That's all I'm saying. And it's a premature statement actually on my part because I haven't read the article. So just with all those caveats,
Yeah, I would agree though. I think that's fair. I think a lot of the criticisms of some of the articles trying to link to the opioid use issue have just been that there's been so much focus on opioids in the last I'd say decade at least nationally, with the opioid epidemic and changing sort of recommendations for prescribing and flooding naloxone everywhere, and having a lot of focus on safe use and all that there's just so many huge, big ecological factors that I think a lot of these studies have a hard time teasing that out.
Haley, I think that your point is such a good one, because I think that also notes that the challenges of the work that we're doing and that our small groups are doing, because trying to demonstrate an effect when the country is flooded with fentanyl and is struggling with a mental health crisis. Independent of that, it's incredibly challenging. Yeah. Donna, please.
Yeah, and just so everybody on this committee knows, that one of the things that we're doing from the program standpoint is we have to do a survey every year about access and use. And so we're starting to collect some more longitudinal data. And in fact, part of what we're proposing for the study this year is having some multiple observation points. And some of the questions are specific around opioid use. So it'll be looking specifically at people enrolled in a program and what may be changing as far as either opioid or other polysubstance use and potential reduction. So just so everybody knows that, we're looking further ahead too than just right now, because I do think it's an important part of, it's still very new for having adult use. How many years is this really going to take to be able to do this? And yeah, the population studies aren't really necessarily going to show that impact for these subpopulations of individuals who are actually utilizing. So hopefully that'll help in future years, but well, longitudinal.
Thanks. And while we're thinking of additional questions, is there anyone who would like to present a journal article for our next meeting? If the article of your choosing. And I suspect that you will, if you find one that isn't already in our Zotero, then I suspect that you will remember what I did not remember, which is to put in the article in Zotero. And it's okay if you don't yet know what the article is on. Hallie, was that a wave, or was that you're going to present?
Yeah, I'd be happy to present something, sure.
Yes. Okay, thank you.
Tell me the date first so that I'm sure I'm not off.
Oh, I think is sure.
My granddaughter's bat mitzvah or something.
Oh, yeah, okay. I wonder if, of course, usually we do that at the end of the meeting if it makes your life better. I know that we are next on our agenda. We have other items from the committee members, but then it is just scheduling. So maybe we'll just swap that on the agenda. And Gary, thank you. So that of course our 2 months would land us in December, which is a pretty busy time for a lot of people. I'm going to not completely randomly, but just throw out the 19th at the same time. That's Tuesday the 19th. It's the third Tuesday. And I'm not attached to it. It was just because it was on my phone. So I see, I'm just looking up now. So if people started nodding, then I may have missed it. So maybe I will ask that if Thursday the 19th works for you, if you could put a thumbs up.
Tuesday, right?
I said, thank you. Look at you paying attention. Thank you. Yeah, so it was Tuesday. Yeah. All right. So I see lots of thumbs ups. I didn't see, can I see a hear from anybody who can't make it?
I can't find the thumbs up
Okay.
item. Where is it? But anyhow, you have it.
Okay, I saw your thumb. Sounds like I didn't see anybody indicate they can't make it, so it sounds like that we're set for then. And Hallie, thank you for presenting. Okay. So that next brings us back to on the agenda, are there other items from committee members that we should be discussing? What are your items? Okay, I counted to 10 and I didn't see anybody raise their hand or frantically wave. So I think I'm gonna take that to mean that people are really still thinking about what is the work that they need and want to do for their small groups. I wonder if, since it obviously I did a terrible job trying to share my screen, if do we wish to maybe share screen of the, I can figure out how to do that, of who the groups are in case people want to take time right now. If we were to adjourn the meeting, stop the recording, that people could reach out to each other to have a phone call meeting. Thank you for showing that. And I welcome if anybody wants to add into the chat or just unmute yourself to plan to meet with anybody else who's on the call.
Yeah, and one thing is that we might be able to actually break people up into small groups. I believe that Libby had done some research with regards to how we could accomplish that. We could attempt to do that. But did we want to adjourn the meeting first and then attempt to break up into the small groups? Okay.
I think you're right.
We have to talk about who wants to go where, I think, first.
Well, and I've sort of been brainstorming that. Child Access met the other day, so I think that group is probably, those individuals would want to participate in a different section. But road safety and workplace safety, Libby, if you could put Matthew, Allen, and I in a room,
Sure.
we could address those two topics. The percentage of ER visits, Eleni, Mateo, and Haley could tackle that. They're all here. And then Crystal and Katie are gone. So yeah, again, Mateo that would be the only group that Mateo really could participate in. And of course, Hallie and Eileen, whatever groups you would want to participate in. Now, so Eleni would be, I guess, product safety could be another. We could talk about that some more. I don't want to leave you out, but that's just sort of how I sort of see the breakdown based upon the attendance.
Sure.
But if we all do get disconnected, as we do try to attempt breaking up into these rooms, of course, here is the data. Let me ask this question. Would it help to put phone numbers on this page?
I can just assign people right now.
Okay, but just for going forward, is that something people would prefer to have instead of email? Okay. Well, I'll add numbers then so that that's a backup way of communication. Okay. How's it going, Libby?
I just need to know where Hallie and Eileen need to go or would like to go. So I've got Alan and Matthew and Gary in a group. Does anybody want to join that group?
I've lost track. So I'd be happy to join the consumer and the road safety and impaired driving group, which I think is together.
Okay, I'm gonna put you all together. Sorry. Okay. And then we've got emergency room visits and outcomes. We can do, I don't know if Mateo is still present, but Haley and Eleni, I can put you there together. Haley and Eleni, and maybe Eileen, you want to join that group? Sorry, I can't see you if you shook your head.
Sorry, that was a thumbs up.
Oh, okay.
A silent thumbs up. Thank you.
Okay. I will also join that group. And I think that's everyone. Okay. I'm gonna put you all in room 2. Okay. And everybody else, you are free to go. Thank you all. And so just to reiterate, December 19th is our next meeting, and I will send out an invite within the next few days. So it's on your calendars, and we will see you then.
Thank you, Libby. Thank you, everybody. Take good care, stay safe, and happy Halloween and happy Thanksgiving.
Thank you. Same to you. Bye, everyone.
Bye.
Bye. Thank you. Look forward to next.
So there's a little, it says join room. I think we just